Go ahead, Dr. Casper.
All right, thank you, Linda, and a big thank you to the Seattle Science Foundation for hosting us this evening. I hope we have some good cases in store for everyone that's been able to join us tonight. We're taking a little bit of a different route than our traditional approach, in that we're going in the direction of kind of preoperative planning. Now, a lot of the cases we have tonight are a little bit more on the complex side, but as a younger faculty member, certainly over the past year or so, I've realized the importance of preoperative planning and the necessity even for the most basic of cases, whether it's the microdisc done at a surgery center and what happens when you get that durotomy, and your alternative plans up to the most comprehensive deformity case. And we certainly have some of those to highlight. So our discussion for this evening is really just kind of taking you through those individual preoperative plans, whether it be plan A, and hopefully, all things considered, that's exactly how things go, but knowing that we need to have in motion plan B, plan C. And, obviously you can see from two of these cases, I'm sure they didn't start with this initial construct. So just knowing what, even not necessarily during that operative case, but what happens down the road when you have a failure, what happens, 2 cases down the road when you have a failure. Ideally, we like to have one surgery and be done, but we know that unfortunately, that's not necessarily the truth within spine surgery itself. So I think we have 6 cases tonight that will hopefully just demonstrate some of this importance of preoperative planning. And with that, I'd like to turn it over to our head of deformity surgery here at Penn, Dr. Arlay, if you'd like to make a few comments.
Thank you, David. Thank you, Linda and the Seattle Science Foundation. So a couple of months ago, when we had asked to present the Penn medicine cases, David and I sat down and we thought to discuss the different strategy in a case were always good. And when I look back at my 25, 30 years of spine surgery, I remember that lots of my plan A or B were coming from my mentors. I was asking them for any cases, what would you do? What should I do? What if, what if, what if? And over the years, obviously, the plan B and C came with some bad events that happened to me during the surgery, or even after the surgery, had to go back to a plan B. But the rest of it, the plan B and C, I've learned a lot from a conference like this, talking to my friends, talking to my colleagues, exchanging my own cases where I thought I had come with a good plan B, and the other folks told me, well, I would have done a little bit differently. I said, well, that made a lot of sense. Maybe next time I would do what they tell me. So I think the spine surgery is very collegial, as you know. We have to learn from all our friends. It's a camaraderie, and we'd like to share our experience. I will bring us a few cases by our fellows. We're going to have the 3 fellows, they will introduce themselves for each case, and it's been a great year just working with them. So why don't we get started? David, what's the first case?
Absolutely. Thanks, Dr. Arlay. We'll start with Jay Reidler, who's been a fantastic fellow we've had thus far. Nothing but glowing remarks about him. He's going to start with a case, and what I will ask, I'll keep my eye on the chat box, so if any questions come up, Jay, I may interrupt you from time to time. Please feel free, anyone on the call, to message us with anything that may arise. And Jay, with that, go ahead and take it away.
Okay, great. Thank you very much. I'm very excited for this evening. So our first case is a 53-year-old gentleman who presented with persistent low back pain and right lower extremity radiculopathy. Now, he's had multiple prior posterior lumbar surgeries by an outside surgeon, and here's his course. It started with, in 2018, he had an L4 to S1 hemilaminectomy and discectomy. 2 years later, in 2020, he ended up with an L4 to S1 posterior spinal instrumentation infusion and decompression. This surgery was complicated 1 month later by requiring a return to OR for a washout for persistent pseudomeningocele versus seroma. The operative reports were not entirely clear. And then 1 month later after that, he unfortunately had to return again for a dislodged rod. That rod was replaced, and nothing was done to the screws. 6 months after that, he developed pain that improved following a right L3-4 synovial cyst aspiration. So currently on his presentation, he localizes his pain to the low back, as well as pain radiating down into the right lower extremity. The particular dermatomes, including buttock, posterior thigh, calf, and into the foot and great toe region. And so our thought was that the dermatomal distribution he was having pain is most likely in the L5, S1 areas. His pain is worse with ambulation, as well as flexion and extension, and it gets better with rest. His past surgical history is notable for multiple prior abdominal surgeries for ulcerative colitis, including a total colectomy. On physical exam, his posterior incision was well healed. He was sensation intact to light touch, and he had 5 out of 5 strength, except for a 4 out of 5 right ankle dorsiflexion and 4+ out of 5 left ankle dorsiflexion. So here are his AP and lateral radiographs. You can see the prior instrumentation. There are lucencies around at least the top screws, and you see some bone formation around the top screws as well. You see that the lumbar spine is fused in a somewhat kyphotic position with only about 18 degrees of lumbar lordosis between L4 and S1. And here is his flexion extension views. There's no gross movement at the fused levels or the instrumented levels. You see some motion at the levels above that. Here's CT of lumbar spine showing lucency around the top screws. And then you can see at the levels below that, there are lucencies that are slightly more subtle, but present as well. So essentially all the screws are somewhat loose. Here's the MRI showing a cyst on the right side at L3-4, and this was the MRI that predated his synovial cyst aspiration. And so this was addressed, and the pain that was associated with the L3, L4 distribution appeared to have improved following that. You can see he does have residual stenosis at the levels that were operated on before, L4, 5, and L5S1. You can see here, I have some arrows pointing to areas of foraminal stenosis that you can see. And so in terms of the options, multiple options were considered. There's that possibility of going back into, similarly to before, going in posteriorly, potentially dissecting through all the scar, potentially removing all the instrumentation, performing T-lifts, and so on. Alternatively, go anterior. The big challenge with anterior, as I mentioned before, is that he's had a total colectomy. Combined anterior posterior approaches. And then the other main question is address L4 to S1, which appear to correlate mostly with his current symptoms, or address L3 to S1 since he does have that synovial cyst at the level above. So Dr. Casper, do you want me to proceed from here, or any discussion?
Thank you. And let me interject here now. In your practice, which you're going to be out in a few years, this is obviously one that's a little bit of a head scratcher. He comes into your clinic, he's had 4 operations done by an outside surgeon. You may have a big pseudomeningocele mess in the back. Clearly he's got pseudoarthroses, and he also has foraminal stenosis. So it seems like, he's maybe even fused a little bit in kyphosis. He has ongoing stenosis, and he also has a mess posteriorly. So, from your thought process in terms of what you're counseling this patient on preoperatively, what your goals of the surgery are, how are you kind of addressing that when you first step into the office? And what's kind of your thought process in terms of how you're going to get him to where he wants to be?
So obviously, I think you have to paint somewhat of a bleak picture in terms of setting his expectations. He's had multiple surgeries. He wants this to be his last. Unfortunately, just looking at his spine, it may not be his last. And depending on how extensive of a surgery we want to do now, we may want to go for something more minimal, given that there's multiple, there's several risks. If we go posterior, there's several risks. If we go anterior, if we go with a combined anterior posterior, then we're taking on all those risks at once. And so, setting out expectations, there's a good chance you're going to end up, if we go with only a single approach, that you may end up requiring further surgery in the future. I think that deciding between the anterior and posterior is going to be in large part having to do with a discussion with my approach surgeon. because I don't have that much experience operating on patients with prior total colectomies, and I don't know how risky that will be getting down to the anterior spine with that in mind. And so it will.
Jay, I think you're spot on with that, and I think that's very much a conversation that, when you get out in practice, you got to make sure that you know your approach surgeon, you know a good plastic surgeon, you know a good ID doc, and I think, having that conversation, if you choose to do an anterior approach, and we talk about Plan B, the alternative is, well, if you can't get you to those levels, you can always bail, and hopefully no harm, no foul. So I think that's a very logical thought process in terms of how you're addressing that. Dr. Khalsa, I know that you're on the line, and obviously this is your case. What were some of the things that you were kicking around before you kind of decided to pull the trigger in the direction you did?
Yeah, I think we were trying to go for a single or double here, not hit a grand slam. I think if we could somewhat mitigate his intractable back pain secondary to pseudoarthrosis, as Jay poignantly noted, we're not guaranteeing this patient that his longstanding weakness is going to resolve. So that was in mind when we, made the initial plan A, B, and C for this gentleman, which I'll let Jay kind of advance here.
Okay, so ultimately, Dr. Khalsa spoke with our approach surgeon, Dr. Martin Niels. He's a trauma surgeon with pretty extensive experience performing anterior approaches on very complex spines. And he felt that it wouldn't be a simple approach, but it was a feasible approach. And so ultimately, we opted to proceed with an ALIF L4-5, L5-S1. And really, again, not focusing on L3-4, limiting it to L4-5 and L5-S1, where we felt like the symptoms were currently coming from. And that's what we did. One of the most important things that we did in the process was we consulted urology, who placed ureteral stents, because ultimately we ended up having to perform a transperitoneal approach. And even if we were to do a retroperitoneal approach, either way, it's very helpful to have stents in the ureter so that as you're doing the approach, you really have a palpable feel of, you can feel the stents placed there and know that you're avoiding ureter injury in the process. There really was no retroperitoneum any longer. Everything from all the prior surgeries, the moment we got past our initial approach, we were in the peritoneum and continued with the transperitoneal approach, which was fine, just retracting all the small bowels. It was challenging, but we ultimately were able to get down to L4-5 reasonably efficiently. This was what it looked like after our L4-5 ALIF was completed. You can see we were able to get a fair amount of lordosis from that level. And then we proceeded to try to dissect out L5-S1. And that's when we encountered a very substantial problem. So there was a J pouch. And our surgeon anticipated there might be one, but wasn't anticipating the extent to which this J pouch had essentially stuck down to the sacrum and was covering up our L5-S1 area. And so what is a J pouch? Well, after you've taken out the entire colon, you need an area to basically store stool if you're not going to have an ostomy. And so basically this is a diagram from the Cleveland Clinic showing a J pouch where you basically take part of the small bowels and create this little pouch where the stool can be stored. And usually it will sort of sit in the back, but in this particular circumstance, that J pouch had totally scarred down to the sacrum and was completely covering up the L5-S1 disc base. And so at that point we had, encountered the significant problem, which got rid of our initial plan, which was just do an L5-S1 approach, medial to iliac vessels as usual. And, there's the possibility of mobilizing the J pouch, and we started doing that. And it was just totally stuck down. It was not something that we felt can safely be done. And important also to note that if you violate the J pouch in the process of mobilizing it, not only are you going to contaminate the entire field, but you also might be committing him to significant further, intestinal surgery in the future. And so that plan was ultimately nixed. So now the questions are, what alternatives do we have? So one alternative was attempt L5S1 approach lateral to the iliac vessels. Very non-traditional, but it is something that will occasionally be done. Another consideration was, just close up. We've encountered enough difficulty for the day, and then just go posteriorly to try to revise the L5S1 pseudoarthrosis. And finally, the option that we ultimately went with was to perform an L5S1 anterior interbody fusion using a reverse Bowman technique. Now, before going into that a little bit, I'll just point out we did consider and even attempt the L5S1 approach from the lateral to the iliac vessels. And unfortunately, that was just not working. We initially encountered some mild bleeding that was getting us more and more nervous, and ultimately the surgeon felt like that was just not safe, and so we decided not to proceed with that. But it was a good consideration at the time. So ultimately we proceeded with a reverse Bowman technique. So what is that exactly? Essentially, we drill from the exposed anterior L5 vertebral body through the disc space and down into the S1 vertebral body. We had enough exposed proximally, and I'd say this diagram we were not drilling as caudal as this diagram shows. We were pretty much starting at the top of the L5 vertebral body because the J pouch was kind of scarred down, probably from the midpoint down. So we drilled that. And if I recall correctly, I think we used kind of we called for a pelvic screw set that you might use for acetabular fractures or pelvic cubic rami fractures. And we took like a 6.3 or 7, 6.5 or 7.3 drill and essentially drilled across that space, used some fluoro to help guide us, and then placed a fibular allograft into that space. And you can't really see it too well, but here's a zoomed in image. You can see there's this little spike that's connecting the two vertebral bodies currently. And then here's the post films, and then just our pre and post imaging. And we closed up, and that's where we left things off. So
that's great, Jay. I hope I never hear any more about J pouches. I think that's more than anyone on this call wanted to know. But I think it certainly highlights the importance of making sure that you have your alternatives in place. Dr. Colson, would you mind just kind of taking us through your thought process at the time? It's pretty easy reflecting back, but I'm sure when you were going into this, you weren't necessarily thinking of reverse Bowman. You didn't have your ACL reamers pulled. That was probably plan F, and somehow you were able to jump to it.
Yeah, I mean, I think that clearly there was a robust pseudoarthrosis at 4.5. I don't think anyone would feel comfortable with an anterior only stabilization for the 4.5 level with just a reverse Bowman, fibular strut. Now, I will say we did utilize BMP in interbody space at both levels here. So, very robust pseudoarthrosis at L4-5, a little bit more subtle at L5S1 that made us feel more comfortable with a little bit less of a rigid construct that we did there. Proof is in the pudding. This guy is actually doing well, and he's making some significant progress. So, obviously not the ideal fixation, but I think we made the best of what we had. And extensive discussion with this patient, before surgery that, we're going to give our best shot with anterior only fixation options. And, if we need to down the line, we can consider going back in posteriorly, but, that was just going to open up a whole can of worms that we didn't want to get into if we could avoid it. There were some good, comments in the chat section. Inflammatory labs were normalized, but you never know, there could be risk for infection. And that was discussed with the patient with utilizing BMP as well. And then obviously a pretty clear pseudomeningocele, and a lot of revision scar tissue. So, if we could avoid it in this patient particularly, I think it was worthwhile. And I think, we dodged a bullet here, thankfully.
I think those are great points. Fingers crossed he fuses. Dr. Chapman, the posterior hardware, the loose hardware was left in place with the hope that that 4-5 ALIF, and then the reverse Bowman will get him diffused, but I think only time will tell. If there's any more questions, please feel free to list them in the chat box. Otherwise, we'll keep moving to Ryan Monsman, another one of our fellows. Fantastic job this year, Ryan. Can we get started with your first case?
Sorry, forgot I was muted. So first case actually took place in 2015. It's a 56-year-old male who is now 56, I'm sorry, 50 at the time of operation, who was complaining of persistent back pain, leg heaviness, and weakness. Prior treatment, no physical therapy or injections, had been taking over-the-counter medications with little relief. And his previous treatment was for lower back pain and had an L5-S1 ALIF a year prior with posterior spinal fusion. He had been having pain prior to that for a few years and prolonged to the point of becoming so debilitating that he was laid off from his job. Modifiable risk factors are just that he's morbidly obese at 32, but no diabetes, not on any blood thinners. So in his review of systems, really just complaining of weakness in both of his legs, numbness in the bottom of both of his feet. His neurologic exam was otherwise okay. Good motion, good strength, and no imbalance in his spine. So unfortunately, all we really had from this time that had been uploaded into our system was a pretty focused lumbar X-ray. But you can see that degenerative arthrosis from his previous ALIF at L5-S1. We did have reports from CT and MRI and FlexX, again, unfortunately not uploaded, but he did have motion at that segment. MRI and CT both showed 3-level degenerative disc disease there at 2-3, 3-4, and 4-5, with an associated gill fragment from that spondylolysis that you see there. So Dr. Casper, I don't know if you want me to kind of cruise through this one here.
Yeah. I think just in the interest of time, I think, obviously we have an ALIF that subsided in the front, and the conversation is, do we address this posterior or anteriorly? But yeah, why don't we keep going here? Yeah.
So he did have a little bit of neurocompression apparently per the MRI. So the plan was to do transperitoneal approach, remove that allograft anteriorly, and place a hyperlordotic cage, and then flip over under the same anesthesia and remove the previous instrumentation and decompress there at 5-1 from the gill fragment, make sure that the neuroforamen there are open, given that he was complaining of numbness almost in an S1 distribution down into the bottom of his feet. And then from that pseudoarthrosis of his screws, remove that instrumentation and upsize it and place a stronger rod. So anteriorly, we were able to complete the transperitoneal approach, get down to the disc and remove that allograft. But while attempting further disc space preparation, there was a laceration to the left common iliac vein. So then, you kind of pivot in that moment. You repair the vein, multiple figure of 8 stitches. They were able to get hemostasis and control the bleeding as well with the retractor system, and complete the anterior fusion using the harm cage. And then in this instance, obviously, you kind of want to abort, make sure that the patient is stabilized. We're able to get away with only about 200 cc's of blood loss, thankfully. Controlled very quickly, and then check the patient post-operatively, make sure that they're doing okay. So we get a CT. There's no obvious hematoma or anything problematic that's brewing. You can kind of see that harms cage, and as well with the harms cage, we placed it was a 25 millimeter long screw with a washer in place to almost also add a little bit of pressure to that left common iliac vein, and then just I put the reference image there on the far right. So that's not a post-operative X-ray. That's the original X-ray. So gave the patient a couple of days to cool off, made sure that they remained hemodynamically stable with the ALIF now in place and the patient in a good position. And a 2-day delay, we took the patient back, removed that instrumentation, completed the decompression, made sure that the nerve roots were properly decompressed, and then replaced and upsized the instrumentation and placed a stronger rod.
Ryan, very nice job. Dr. Arle, in terms of your experience with these A-lifts, obviously, some younger surgeons such as myself haven't used the harms cage as much. We have these A-lift cages, expandable cages. Can you walk us through some of your experience and what you felt was appropriate about the harms cage in this case? And then also, I love your washer and your screw, especially in relation to the vessel repair. So maybe just a comment on that, if you wouldn't mind.
Yeah, just obviously, when you get iliac vein laceration, you have the first thing you have to control the bleeding. The best way I find is to control the bleeding is always to have on the table long peanuts and then a small sponge on the stick and always a flow seal, gel foam, Surgicel, not in one of the closets in our room, but on the table. Let's always ask wherever the scrub is to get on the table. So when it bleeds, you just get the peanut and you compress and you control the bleeding. Then afterwards, you have to often replace the blade retractor to recontrol the bleeding, and you ask for help. Because most of the time when the bleeding happens, the access surgeon is not there. You always, all this medical issue is you have to get the access surgeon to do the approach of everything, but when there's a bleeding happens, he's never there. So the key is to control the bleeding, and that's our responsibility to control it. And the best way is a combination of peanut and the blade retractors and some local compression, not all compression. So this gives you the time to call for help. So the approach surgeon came back and did a good repair. But then obviously to put the cage I was planning to put in didn't make any sense because I would have lacerated again or damaged the repair. So that's why I switched to a smaller harms cage. In some cases, I put two small harms cage side to side to have increased the surface area and to get it. Now you have the screw over the washer. This is an anti-kick-out screw to prevent the harms cage to come out. In some cases, we had another case, but it's not going to be presented, have used the screw and the washer to give a little bit of pressure on the left common iliac vein to stop the bleeding. But that's not this case. You see, it's too low. If I had put it, it would be higher. That's not a case where I've used the screw and the washer to stop the bleeding. So you put the screw and the washer inferior to the left common iliac vein, and you put a Surgicel above, and you tighten it a little bit, and it helps to stop the bleeding along with the repair. So I just thought it was an interesting case because vascular injuries happen to all of us. This patient did extremely well for 5 years, and they came back to see me this year for adjacent level spinal stenosis at 3-4, which I decompressed. He had foraminal stenosis. I decompressed him at this level, and he did fine. But for the 5 years after his fusion 5-1 for psoriasis, he did very well. And I wanted to share a little bit, what happens to all of us, because sooner or later, we all going to have a vascular injury doing this anterior approach to the spine.
Thank you, Dr. Arle. And I think that's important, and it's something that I don't necessarily think about when I scrub in and the approach surgeon leaves is exactly that, having that sponge stick ready to go, making sure that you're communicating with whoever you're working with, keeping an eye on those vessels, because all it does is it takes one instance where you're not prepared, and it's a big issue. I would like to note, Dr. Arle and I were joking earlier on the prior x-ray, you could see, for those of you who think Dr. Arle only does massive deformity surgery, he did have percutaneous instrumentation posteriorly. So I thought that was a nice little touch.
Me ask Jack, who has lots of experience in anterior surgery, what do you do when you have a vascular injury of the left common iliac vein? What's your algorithm, Jack?
Yeah, I mean, we're lucky because our access surgeon, the vascular surgeon, stays with us during the case. That's just been the tradition. So it's always a lot more reassuring when he's right there. But it's the same principles that you described. It's, try to stop the bleeding, get some limited control above and below, and then try to do a primary repair. The vascular surgeons just spend a lot of their years training with these double-armed sutures that we can barely see, and they're very facile getting knots down way down into an abdomen. So, it's wonderful what they can do. But as you said, once you make that repair, you can't be so bold to start going back into the disc space and distracting and putting in a normal implant. You have to fall back to some other plan, as you did, which, it may not be what you wanted to do, but the main purpose here was to get a fusion, which you did. So I think that's a good illustration of what you have to do once the bullet starts flying. There's a saying in the military that a battle plan ends when the first bullet is fired. So it's the same thing in surgery. Oftentimes our plans change very dramatically in the middle of our battle. So, you got the fusion done, and that's what counts. And the patient hemodynamically got through this. So good job.
What I've done as well for some vascular injury as well is to control it with the blade retractors so it wouldn't bleed, and being able to finish my anterior fusion or disc replacement. And then once it's done, just call my vascular colleagues and remove the blade on the tippy toes, and if needed, do a vascular repair at this time.
Yeah, I think certainly all important points to consider. Ryan, would you mind just advancing the slides? And I think we have Jay presenting his second case.
All right, thank you. Just trying to advance the slides. Give me control. All right. Sorry, I think there was just a little delay there. So this is a 54-year-old woman who presented with a progressive adult degenerative scoliosis, severe low back pain, inability to maintain upright posture. In 2018, she underwent a posterior cervical fusion, C2 to T2 by an outside surgeon. And then 3 months later, underwent L1 to F4 posterior spinal instrumentation and fusion with decompression at L2-3, L3-4, and TLIPs at those levels. She has a significant past medical history, including CREST syndrome, malnutrition, non-Hodgkin's lymphoma, bone marrow transplant, respiratory insufficiency. She's had multiple prior abdominal surgeries, including gastric bypass, splenectomy, and hepatectomy. And of note, she had has retroperitoneal lymphadenopathy related to her past cancer. On physical exam, she had forward pitch antalgic reciprocal gait with a rolling walker. She had difficulty maintaining upright posture and had a right coronal shift. She had a well-healed lumbar incision and iliac crest donor site incisions, and significant prominence around the T12 to L1 spinous processes, but no evidence of overlying skin breakdown. She had mild numbness in bilateral toes. And strength was 4 to 5 throughout, with 3 out of 5 at the left tibant and EHL. So here are her standing radiographs, and you can see on APN lateral, she has a 40-degree lumbar curve and 32-degree thoracic curve. Her SVA is about 17 centimeters, with her pelvic incidence about 67, but lumbar lordosis at around 18. Here's just the zoomed in view on prior instrumentation. CT shows that she had achieved fusion at the instrumented levels, 1 to 4. And just looking at the chromal views. And on MRI, there was no significant central stenosis, or really at the 4-5 and L5 S1, you see she has significant, she still has some good disc height and open foramen and lateral recesses at those levels.
So Jay, I'll have you pause there, and what I'd like to do is open it up to the panelists in conversation in relation to, iatrogenic flat back, whether or not PSO is the first choice in the algorithm. You have 2 preserved disc spaces here at 4, 5, 5, 1. I'd love to hear some of the panelists' thoughts on how much lordosis they think they can get through a disc space and what their algorithm is, whether it's a, ALIF and then if they don't get the correction they want, is it an osteotomy in the back? Is it straight to an osteotomy? Just perhaps some of the workflow. I know we have Dr. Who does quite a bit. Dr. Lieberman, I'd love to hear your thoughts on this as well.
Sure, thank you. These are obviously very, very complex cases, issues that you do have to come in very prepared. My favorite approach for something like this is staging it. And the first thing I do is take out all the hardware, explore that posterior fusion mass. Very often I will find that there are multiple pseudarthroses from behind, and you can actually set yourself up for success by getting rid of all that hardware first, and then potentially doing some other osteotomies posteriorly in preparation for what you want to get from in front. So I'd probably remove all the hardware, explore the fusion mass, take cultures to make sure that there's no occult infections, then reinvestigate with another CT scan and decide. A lot of the times when you take out the hardware, you'll see post-op, they're already standing taller and straighter because they're not as much pain, and you may be able to get better correction from in front. The other thing you've got to do is make sure that their hips are mobile, that they've got enough extension, because it's hard to tell on these x-rays, but I suspect she may have an element of a fixed flexion contracture of the hip. So even if you get a lot of lumbar lordosis, you may still run into trouble with the hip flexion contractures. So the second and maybe even the third stage will depend on how the first stage goes, what you see between stages, and then you build from there. I've not been a big fan of the hyperlordotic cages. I found that you get point contact, they still subside. You think you're getting 20 degrees, but you don't. The real correction comes with a lordotic cage in front, 15 degrees maybe, and then doing a generous facetectomy behind and closing it down. So that's how I'd plan her out and stage her.
And that sounds exceedingly reasonable and a great approach. Dr. Lieberman, how long do you wait in between those stages? If you were to remove all the hardware, when are you looking at taking the patient back?
If I am concerned that there may be an occult infection, I'll wait 6 weeks. If all the lab work, everything's fine, and I'm convinced that she's not at all infected, I would probably wait 5 to 7 days between, and then see what it's like, get the investigations, figure out what their leg pain is like. A lot of times they have radicular symptoms, see what's going on there, and then you can build each step of the way.
That sounds great. Jay, would you mind just taking us through kind of some of the next steps and what the thought process was with this particular case?
Sure. Just advancing slides. So the options that were considered, as Dr. Lieberman mentioned, there's the possibility of going with hyperlordotic ALIFs at L4, L5, L5S1. That would be part of an anterior and posterior procedure. And this was actually our plan going in. Now, we were sort of planning out plan B, plan C, if we were not able to do that for some reason. As mentioned before, she had a very complex anterior approach, similar to the first case that I presented. And so we weren't sure whether we would even be able to get down to L4 to S1 anteriorly. So we figured if we are not able to get there access anteriorly, then our next stage would probably be just close up anteriorly and proceed with the posterior correction. With our plan B being trying to achieve correction with posterior column osteotomies and bilateral lordotic T-lifts at L4 to S1. And then see how that works. Now, if things were too stiff and we were not able to achieve adequate correction, because again, our goal was probably around 40 degrees of increased lordosis in the lumbar spine. If we weren't able to achieve that, then the next step would probably be a pedicle subtraction osteotomy. And we hadn't quite decided exactly where that would be, but in general, we prefer doing that lower down to try to prevent injury to L2, L3 nerve roots, which would make things much more severe if there was a nerve injury in terms of ambulation. So that's kind of our thought process, our plans at A, B, and C going into the surgery.
That's
Yeah,
great.
you mind if I just comment here? So, this was a lady I've been following for probably about 2 to 3 years. And, she's at the point I kept telling her, you're not a surgical candidate. You're not a surgical candidate. You're not a surgical candidate. So, as some of the chat comments pointed out, we boosted her nutrition best we could over a year previously, got her on Forteo. And, even at that point, I wasn't committed to doing her surgery. And the last step for her, actually giving her, kind of cachectic overall status was, I had her go see plastic surgeons too, and just say, hey, am I crazy? Are you guys going to be able to cover this up? This skinny little lady, we're going to, fuse her down to her pelvis. Are we going to be able to, just get soft tissue coverage? And with most adult deformity patients, at least in my practice, the hard conversation came around, would you rather die than go on living like you're living right now? And that's kind of, was the kind of the preoperative discussion for her, because, this was a highly complex procedure for her, highly morbid for her, given her just every possible risk factor for having something go wrong, minus infection. She had it, fused to T2 already. It's also a point of discussion, if this woman did not have a previous, cervical thoracic fusion, are people considering a T4 to pelvis? So are we having to do a shortened construct because of that? So, just a lot of considerations here for me. And, I'll just say that the OR, was not happy, morning of this case, because there were just mountains of trays for plans A through F.
That's great. Yeah, I think that the takeaway is, and obviously not the case here, but this is not a patient you meet, once in your office and sign up for surgery. Jay, would you mind just taking us through kind of the case itself?
Sure. So I'll add that in another part of our plan was cement augmentation at the UIV and one level below that, and then vertebroplasty at the level above to try to help prevent PJK, just given her overall metabolic status. So we went anteriorly. The discs opened up very nicely. The approach was complex, but thankfully there was no J pouch there. And we were able to get to both L5, L4-5 and L5-S1. And here you could see some snapshots of fluoroscopy after placement of the ALIF cages. And I think that they were about 20-degree cages that were placed.
25, I think.
25, okay. And here's the AP. And then we flipped it. Everything was done the same day. And we removed prior hardware and replaced with new implants, and then extended down. We placed 4 bolts in the pelvis. And then here's what everything looked like at the end of our surgery. So overall, we were able to achieve a nice coronal balance. She had a substantial improvement in her overall lumbar lordosis, which went from about, I think it was about 18 to 65. And her SBA went to 2 centimeters. Here's her pre and post films right side by side.
Yeah, obviously a lot of points of consideration for this case. I think in the interest of time, Jay, I think this is great. We'll move on to the next one. But if anyone again has any questions, please feel free to answer in the chat box. Ryan, I think this is your last case, and if we can just we'll try and expeditiously get through this one just so we can have some conversation at the end of it. So I'll try not to interrupt you.
There we go. Sorry. So 34-year-old female, history of osteosarcoma, presents complaining of recent onset of numbness, leg pain, and on the right with bladder and bowel incontinence. Of note, she presented to the hospital in March of 2020 and underwent a right thoracotomy, resection of a large chest wall mass, ribs 6 through 8, and a partial resection of diaphragm and right upper and right lower lobe wedge resections that was confirmed osteosarcoma with negative margins. She did not undergo any adjuvant therapy after that. So when she presented to us, she, aside from her lower extremity symptoms, she was also complaining of some heaviness in her upper extremities. She normally ambulates with a walker, but this had been getting worse. So she was 4- out of 5 diffusely in her upper extremities and got weaker distally, and then 2 out of 5 throughout her right lower extremity and 4 out of 5 in her left lower extremity. So patient had come through the ED, and so she just went for stat MRIs of her neuroaxis. So her brain was negative, and her cervical spine, you can see the stir on the left, T2 on the right, cutting through at 5, 6, and 7 there with some pretty significant stenosis. You can see the marrow abnormalities there at C2, 6, and 7 with bony involvement. C6, you've got bilateral pedicle involvement and some right pedicle involvement there at C7. And then there's also an extra osseous soft tissue extension into the prevertebral and paravertebral, as well as obviously the epidural spaces there. Her thoracic spine was also clean with no stenosis or no other masses. But here you see T2 sagittal image and then a T1 post-contrast image here with subsequent axial cuts through both those levels. You can make out this epidural neoplasm in the right lateral and dorsal epidural space there at T12 and L1, causing severe spinal stenosis. And then she also had a extra osseous neoplasm that extended into the right T12 and L1 neuroforamen. And then of note, her metastatic disease also involved L1, L5, and her pelvis, and then liver, right chest wall, right lateral abdominal wall, and right femur.
So thanks, Ryan. I'll just expedite this a little bit in the interest of time. So this was a case that, you know, she actually has 2 problems going on at once. And the question is, do we address them both at the same time? Do we stage them? How do we go about this? So we elected to go forward with kind of 2 surgical teams, 2 attendings, one working on the cervical spine while one working on the thoracic spine.
Yeah, so simultaneous approach, posterior fusion from C4 to C7, and then with subsequent decompression, and then T12L1 decompression. Let's see if I can click through. Yeah, T12L1 decompression with T11 to L2 posterior instrumented fusion.
Ryan. So, you know, obviously this isn't the most common of cases of metastatic osteosarcoma that's present in multiple locations, but I think when someone initially presents with, you know, her long-term complaint had been lower extremity symptoms, and now she presents with both issues, you know, plan A of addressing just the thoracolumbar lesion turned into doing them simultaneously. I'd be curious to get, you know, any of the panelists' thoughts or any faculty discussion on addressing 2 areas simultaneously. Obviously, you open yourselves up for complications at both levels. Is this something that people would stage? Is it something that they potentially would address similar to what happened here?
David, as you know, I never do cervical spine lumbar spine surgery together, but this is case. I think it is a perfect exception to do the 2 together. But as a rule of thumb, I never do a cervical spine, lumbar spine at the same time. So it's exceptional. I think this is an exception that was perfect indication to do both at the same time.
Very good.
Yeah,
Thanks.
David, I assume prognosis is not good here. Is there any reason you didn't use cement or something else so that you could, mobilize her right away without having to wait for biologic healing?
I think that's a great point. And, in our minds, we were doing this not for fusion, but for just instrumentation. And yeah, her prognosis is unfortunately less than a year. So it was really trying to give her some independence over the remainder of that year. I think adding cement would certainly be very reasonable to try and give her as robust a fixation as possible. Our thought process was let's get her on and off the table as quick as we can. Obviously, that wouldn't add an extended period of time, but I think that's very valuable insight.
Those were great cases, and for your fellow standpoint, these are good cases to see as a fellow. A, because they're not yours, and B, because you kind of can deal with the intellectual part of trying to think on your feet, have an action plan, but be able to pivot intraoperatively. So these were great for, I think, surgeons at all levels of experience to see. Really,
Jack, you mean just to being as a fellow is to live on somebody else's credit card?
Exactly right. If we have time, we'll Stefan, if you wouldn't mind, we have, we can maybe do one last quick one, maybe just in an expedited fashion, and we can certainly wrap up at I guess it'd be 9 o'clock our time. But if you want to get started, and we can just kind of show a few quick points and then advance from there.
Sure, I'll certainly attempt my best. This is a interesting case that surely can take up to an hour to present. There were so many deviations in the care of this patient. But I'll start quickly, and I'll try to cruise through this in the next couple of minutes so we can have some discussion. This is a 68-year-old gentleman who presented with basically some degenerative scoliosis that was treated in an outside facility, had a 1 to S1 decompression and a 2 to 4 fusion. But he presented to us because he had some relief of symptoms post-operatively, but when he started PT, they all came back. He required a cane for assistance. He had ambulatory dysfunction. He had, and on further examination and discussion with him, he had dexterity issues, so we were automatically concerned for the cervical spine. So on further imaging of the cervical spine and, assessment, he had clearly, some degenerative changes along the cervical spine. And on the MRI, there was significant stenosis, and he was notably in myelopathic on exam with positive Hoffman's, finger escape sign, tandem gait difficulties. And so we'd elected to perform a 3-level discectomy infusion. But approximately 2 years later, within that time, in that 2-year span, he had developed an acute osteomyelitis of his foot. And 2 years after his ACDF, which went great, he had improvement of his symptoms, but then he was critically ill. He was thrown in the ICU. He was septic. An initial screening MRI showed that he had a significant epidural abscess with osteomyelitis along his lumbosacral junction. And so initially, to kind of get him symptomatically controlled with his sepsis, he was taken back for a corpectomy at L4-5 with strut graft, doing a combined anterior and posterior with a fusion from 2 to pelvis. Pseudomeningocele was found posteriorly that was repaired with a fat interpositional graft, but then he was also pan-scanned. The problem was that he couldn't tolerate the procedure. He was able to get the front back procedure done, but he was floridly septic. And so once he finally got formally pan-scanned, sorry, I jumped ahead. This was his lumbar spine that showed the corpectomy that we did a 2-level corpectomy at 4-5, and he was fused posteriorly. And he actually had an excellent result from this, but again, he was still persistently septic in the ICU, intubated, and a cervical MRI was ordered. On the cervical MRI, he had this large epidural abscess, and Dr. Smith and the thoracic surgery team was like, this guy's really sick. We obviously have to address his cervical spine at the same time. So apart from just his lumbar spine, doing a front back procedure to kind of symptomatically control him, he had a significant phlegmon that extended into his mediastinum. And so he was taken back to the OR with the assistance of cardiothoracic surgery. And when the patient was placed on the table, he was unable to ventilate. He was hemodynamically unstable. Anesthesia was adamant about canceling, but the problem was that every time we attempted to take him back to the OR, they were trying to cancel. He'd become unstable. And so cardiothoracic surgery and Dr. Smith were arguing with anesthesia, if this patient doesn't get decompressed from the front, he's going to die. And so they did a cervical IND. The phlegmon actually extended to the artery of the aorta. There was an aggressive debridement. They removed the ACDF plate. The interbody device at 4.5 was well fused, even though there was a large rim enhancing lesion around it. But the C6-7 interbody device was removed at the time. A drain was placed. He was packed with wet gauze, and he was transferred immediately to the ICU to minimize operative time. And he tolerated that and was able to get back to the ICU. He was taken back to the OR when he was able. It was probably a week later. The interbody device again was removed. He had a tricortical iliocrest bone graft that was placed in that intervening segment at 6-7. And then they weren't able to flip him posteriorly to do PCDF. So he went back to the ICU. And so a few days later, again, we attempted to take him back for the posterior portion. And on approach of the posterior portion, this is just some images I'll bypass. On the posterior approach, a large abscess pocket was found in the muscle belly posteriorly. He returned to the OR. Well, actually, we flipped him back. We left some packing in that area, and then we took him back to the OR about a week later, but that infection was present all the way down to the bone, so we had to abort doing any kind of instrumentation posteriorly. So he was ultimately placed in halo gravity traction in order to stabilize the cervical spine, because we had no hardware anteriorly. The only thing that we could place was a tricortical iliocrest bone graft back at 6-7, because the other ones were relatively well fixed. And so he actually survived this epic saga and ended up, decorating his halo vest for Christmas, because he was in there for approximately a couple months with this multiple returns to the OR. On follow-up, there was no recurrence of infection. He was developing a slight kyphosis anteriorly on the cervical spine. Posteriorly, he had recurrent posterior abscesses that were drained by IR. And then he had adjacent segment breakdown at 7 and T1. This is how he fused uninstrumented. And you could see there's some slight kyphosis developing at the proximal segment. And this is an MRI cut showing some of those repeat abscesses in the back. And you could see that adjacent segment degeneration at 7-1, but on an extensive discussion with the family, they elected not to do anything. He seems to symptomatically be well controlled, showing no evidence of myelopathy, ambulating without issues, just with an assisted device. And he was living on bought time, given the amount of how sick he was in the multiple returns to the OR. But if it wasn't for like Dr. Smith and doing that aggressive work with getting him back to the OR and doing a formal debridement, it's just an interesting case just to show. I wish I had some more time, but given that time, I'd open it to the discussion about this case.
Thanks, Stefan. And I think the big point about these infection cases is all bets are off and you got to leave everything on the table. Dr. Smith, do you have any closing comments before we wrap up here?
Thank you. No, I mean, we're short on time. I didn't think the guy was going to live when I met him. He was so sick, and he's doing okay now. He's on chronic antibiotic suppression, but I think the key teaching point would be he had this massive anterior cervical abscess, and everyone was saying he was too sick to go to the OR. Basically, I was so lucky that our cardiothoracic surgeon was also the chief surgeon of the hospital, and everybody saying he was too sick to go to the OR. Our point was, if we don't get him to the OR and decompress, he's going to die. And so we, against the objections of numerous people, rushed him to the OR. The cardiothoracic surgeon was there also to scope the esophagus, because part of your differential needs to be there, maybe an esophageal injury. And so we washed out the mediastinum, or literally washed the esophagus, and then sort of got him decompressed, and he lived. But I think it's sort of the teaching point. I think is just, when you're you got to take control of the patient and got to do the best you can. So we advocated for him, got him the OR, and not to be arrogant, we saved his life. I think it was a good result, and I think the key finish is you've got to decompress these abscesses. And if people are saying they're too sick to go at some point, you got to go. Just get it fixed.
Great. Well, thank you, Dr. Ziegler. I sincerely appreciate your time, and I appreciate Seattle Science Foundation hosting us. And it's always a pleasure and a treat whenever we get to do this. So thanks again, and thank you everyone for tuning in.
Super conference. Thank you very much, guys. All right,
Thank you very
everybody,
much.
stay well.
Good job, David.
See you
Bye,
soon.
Jack.
Take care, Vincent.
Thank you.
Thank you, Penn Medicine. Great job.
Thanks, Linda.